Okay. All right. So thank you so much for joining us. Well, hopefully more people will join us. I know we sent out the link again. There may be some people still logging in, but I'll get things started. We again want to thank everyone for attending this webinar on obstructive sleep apnea in patients with Down syndrome. We have an outstanding panel. We really do for today's discussion. First of all, we want to thank the leadership of the American Bronchoesophageal Association, including Dr. Seth Daly, the current president of the ABA and the ABEA, sorry, I keep saying ABA, ABEA and the ABEA Council. Also want to thank Charlotte Grill and Affinity Strategies for putting this webinar together. I'm Romaine Johnson. I'm the Community Outreach Chair for the ABEA. I'm a pediatric otolaryngologist. I specialize in complex airway disorders, and I will be serving as tonight's co-moderator with Dr. Mark Gerber, who is the ABEA's vice president. As I said, we have an awesome panel. Our first panelist is Dr. Stacy Ishman. She's joining us from Cincinnati, Ohio via St. Louis, where she's giving a course. She's a professor of otolaryngology at the University of Cincinnati School of Medicine. And as all of you know, Dr. Ishman is world-renowned expert in pediatric OSA and OSA in children and in children with Down syndrome. She's great to see you again, Stacy. Where are you? I thought I saw your face somewhere, but now I don't. Anyway, great to see you again. Welcome. Next up is Dr. Rupali Druwick. Thanks for being here, Dr. Druwick. She is she's the director of the sleep disorders program at Phoenix Children's Hospital in Phoenix, Arizona. She's a pediatrician by training and an expert in pediatric sleep medicine. And then we have Dr. Sharon Nagney. She also joins us from the great city of Phoenix, Arizona. Dr. Nagney is a pediatric otolaryngologist by training. She's a member of the Phoenix Children's Aerodigestive Team and the Complex Airway Program. And then tonight's co-moderator is Dr. Mark Gerber. As you all know, Dr. Mark Gerber is a ABA-EA's vice president. He's also the chief of pediatric otolaryngology at Phoenix Children's Hospital. Mark, how are you doing? Do you want to say a few words?
Thank you all. Thank you all for coming on board today for this webinar. I'm excited to see this all unfold. So thanks.
All right, just a little bit of housekeeping. Our program will be roughly 60 to 90 minutes, plenty of time for questions, and we want this to be more conversational. We're going to start off with some very brief presentations by each panelist, and then we're going to open up for discussion and questions from the audience. Those who are logged in, why don't you tell me where you're from in the chat, and then also remember to type your questions in the Q&A, and we'll answer them as they come. All right, I'm going to pass things over to Dr. Druwick.
Thank you so much. I'm super excited to be able to be part of this webinar. I'm just going to share my screen and pull up my presentation. All right. So again, I'm the medical director of the sleep disorders program at Phoenix Children's Hospital. I have been there for 15 years. I did my training mostly in the Midwest, in Chicago and Wisconsin. And I'm going to start this just by giving a brief overview of pediatric obstructive sleep apnea. So just some definitions. What is obstructive sleep apnea? Obstructive sleep apnea is a sleep-related breathing disorder that involves a decrease or a complete halt in airflow despite an ongoing effort to breathe. So if we look at the pictures to the right, we have a child lying down, and you can see that the airflow is going from the mouth and freely going through the oropharynx and into the lungs without any obstruction. But in the lower picture, you can see that the airflow is blocked. And this blockage can either happen from tissue within the airway. Many times it's due to big tonsils or adenoids, or you can have external compression, which means that the neck tissue is compressing and collapsing the windpipe. So a hypopnea means that there is a partial obstruction. Some of the air is going through, but not all of it. Apnea means that there's a complete blockage, so there's no airflow going through the airway. Then you can further break down apneas into obstructive apneas or central apneas. So most children who have obstructive sleep apnea have an obstructive event. There's a blockage in the airway, but some children present with central apneas, and that can happen if you have low muscle tone. It can happen occasionally with gastroesophageal reflux, or it can happen if there's a central nervous system issue. The prevalence of pediatric obstructive sleep apnea in the general pediatric population is 0.7 to 2%. But in children who have Down syndrome, the prevalence can be as high as 60%. So why is the prevalence of obstructive sleep apnea in Down syndrome so high? Anatomy accounts for many of the reasons why the incidence is so much higher. Some of these anatomical factors include mid-face hypoplasia, adenoidal hypertrophy, having a large tongue, tonsils, small mandible or jaw, hypothyroidism, low tone contributing to laryngomalacia, or a higher incidence of obesity. What are some of the symptoms of obstructive sleep apnea? How does it present? What kind of symptoms would you look for? Many children who have obstructive sleep apnea present with snoring. You can also have excessive daytime sleepiness, waking up with headaches in the morning, daytime fatigue, difficulty concentrating, mood changes, waking up with chest pain, or waking up with a dry mouth. But children don't always have to present with snoring. So when I see patients in clinic, a lot of times children are sleeping in unusual positions. A lot of children who have Down syndrome, we hear stories that they're sitting up or prefer sleeping in a chair. They're restless, they have frequent awakenings at night. And some may have a couple of these symptoms, or some may have all of these symptoms. So the presentation can be very variable. So it's important to look for any or all of these things. For diagnostic workup, overnight polysomnogram is the gold standard. So over here, you can see an illustration of what an overnight polysomnogram looks like. And there's a lot of wires involved. But despite all of those wires, children are actually able to sleep quite well. So you can see some leads on the head, and we use those to be able to stage sleep. So whether a child is sleeping in the lighter stages of sleep or deeper stages of sleep. We see a band around the chest that tells us if the chest is rising and how well air is getting inside of the lungs. We have a probe that goes around the finger that looks at the oxygen levels. There's a little device that we put right next to the nose to be able to monitor CO2 levels or carbon dioxide levels. And then we put some leads on the legs so we can see if there's any restlessness. Most of the sleep studies that are done for children are in-lab sleep studies. That means they're done in a freestanding sleep center, or they're done in a hospital setting. But more recently, there's some literature coming out that shows that home studies are useful. And so on a case-by-case basis, usually in older children, we've been starting to do home studies. The limitation with a home sleep study is that we're not able to gather all the information that we can gather with a laboratory sleep study. And so if the sleep study that's done at home is normal or negative, and there's still concern for sleep apnea, we would end up having to do an in-lab sleep study. And then if there's multiple risk factors involved, then usually after someone undergoes ENT surgery or has their adenoids or tonsils taken out, we usually repeat the sleep study to look for sleep apnea that is there despite the surgical procedure. So like I had mentioned, the first line of treatment usually is seeing an ear, nose, and throat doctor and undergoing adenotonsillectomy if there is evidence of sleep apnea on the overnight polysomnogram. But some of the other treatments include using CPAP. So you can see an illustration of what CPAP looks like. And basically it's a little mask that sits usually over the nose with headgear in place. And there's pressure that's given through that mask, and it helps stent the airway open so that there's no airway resistance. There's different interfaces that can be used with CPAP. So over here, you can see that this child has a full face mask. It's covering both the nose and mouth, but you can have an interface that just covers the nose, or you can have prongs that go inside of the nose. An emerging treatment is hypoglossal nerve stimulation, which Dr. Nagy is going to talk about. Weight loss or close clinical observation are sometimes treatment, so more conservative. And then dental appliances can be used, not very frequently in the pediatric population, but in older children, it can be used. And basically it helps push the jaw forward and helps augment the airway. What are some complications if sleep apnea is not treated? Well, sleep is super important and it contributes to overall well-being. So if someone is not sleeping well or is not ventilating well at night, it can lead to high blood pressure, glucose intolerance or signs of diabetes, abnormal cholesterol levels, liver dysfunction, anxiety or moodiness, enuresis or bedwetting, or symptoms of ADHD. So just as a summary, obstructive sleep apnea is a sleep-related breathing disorder which limits or halts airflow. Major symptoms include snoring and daytime sleepiness. The gold standard for workup includes an overnight polysomnogram or sleep study. Treatment is usually ENT surgery or CPAP, and hypoglossal nerve stimulator is an emerging new treatment. And with that, I'm going to hand it over to Dr. Ishman.
Thanks so much. I'm going to go ahead and share my screen. And my talk is a little more in depth, but if it seems like I am explaining something that doesn't make sense, please throw questions in the Q&A. And my only disclosure is I do have some research funding from Inspire, which is the hypoglossal nerve stimulator company. Sadly, I get no cash, but we're doing some cool CAT scan surgery looking at people before and after they use their hypoglossal nerve stimulator. I'm also going to talk a little bit about off-label use of nasal steroid called fluticasone and a medication called montelukast. So I'm going to really just talk about some of the management options. And there are non-surgical options, and we've heard about several of these, so I'm not going to go into them much more than what we already heard from my colleague. I will talk a little bit about the Down syndrome specific data specific to weight loss, and then a little bit about the medications. So there was a recent paper that was actually presented at the National Down Syndrome Congress a couple years ago that looked back at all the papers that discussed weight loss in folks with Down syndrome. They found 23 papers, and they noted interventions like physical activity and health education were actually useful in this group. And while that sounds super obvious, there isn't a lot of data out there about weight loss methods for those with Down syndrome. And so it was actually very positive. And then the other thing they looked at is the usefulness of bariatric surgery. And while there's only some case series, meaning there isn't very strong level evidence, it was encouraging that they seem to be effective in at least a small series of kids with Down syndrome and adults. And then when we look at the bariatric surgery folks, I'm not going to go into all these specifics, but one of the big changes they made when they updated these guidelines a couple of years ago was to actually include the fact that folks who had some developmental delay were good candidates for bariatric surgery. And that's really important because I know people were reluctant to take care of some kids with Down syndrome with bariatric surgery for a while. It's not for everybody, but for the selected patient, it can be very useful, and it's gratifying to know that they're including those patients in their recommendations. With regards to medications, there is a group that originally worked out of the University of Chicago who really focused on the use of a medication called montelukast. They did an original trial where they had everybody use it for 16 weeks in kids with mild obstructive sleep apnea. And from my look at it, I don't see that they specifically included anybody with Down syndrome, but they did see that the adenoids got smaller over that time period. And there's some additional studies that have been done. This one was done by a different group out of China. Again, all these kids had already had their tonsils and adenoids came out. And what they found is an improvement in the number of events an hour, or apneas and hypopneas, of 1 or 2 events an hour, a little bit less than that previous trial, which showed 3 or 4 events an hour. There's also some data talking about nasal steroids, which we tend to talk about fluticasone, but this original trial was done with something called budesonide. And basically it showed that snoring decreased, apneas decreased, But interestingly, the ability to breathe through your nose didn't seem like it got so much better from scales from people who did that rating. So nasal steroids did help reduce apneas. And when they used nasal steroids with that montelukast medication, they also found that they were effective, but not more effective than using one or the other. And so this has led to a lot of people considering both of them. I didn't mention it here. Montelukast does have what's called a black box warning, which is a warning from the FDA that in kids who have behavioral issues, specifically suicidality or extreme depression, that it can make that worse. And so that's the one population you have to be most careful of considering the montelukast medication. I'm not going to go into oral appliances. The only thing I'm going to talk about slightly differently is something called rapid maxillary expansion, which is basically when the suture, which is that area right in the middle of the roof of your mouth, before it closes, there's an opportunity to use a palate expander to open it up, and that's what you see in the picture. And there was a review of this technology being used in children with Down syndrome. And what they found is that success rates were slightly less than the control kids who didn't have Down syndrome, 66 versus 78%. They also significantly benefited from slower introduction. So slow activation was carried out in about 30% of the kids with Down syndrome and only 10% of controls. And there was concern from many of the families that they had some more complications or more likely to have oral ulcers was the most common complication. So they were enthusiastic that this may be something that's useful in kids with Down syndrome, but probably introduction needs to be slower than it might be with other kids. When we consider surgery, there's a number of ways to look at kids. One of them is called cine MRI, and it's a fancy way to say it. It's like a movie of an MRI. This technology actually really looked at kids with Down syndrome originally, and this is really where they figured out the kids with Down syndrome don't have big tongues. They actually have a small oral cavity or mouth space for a regular sized tongue. And when they looked at kids with Down syndrome, that was an area they found happened very commonly. They also found the tongue fell back a lot and that adenoids regrew. And then at about 30 to 35% of kids, the lingual tonsils or tonsils on the back of the tongue would get large. And these are some images of that. This happens to be, if you can see my mouse, a very large lingual tonsil, which is what's illustrated here. And when they looked specifically at kids with Down syndrome to see the likelihood of having large lingual tonsils, in this particular study, they found about a third of the kids with Down syndrome had large lingual tonsils, whereas the likelihood in typical kids or kids without trisomy 21 was less than 5%. So it's useful for us to think that this might be an area that's causing obstruction in kids who've already had their tonsils and their adenoids out. Now, drug-induced sleep endoscopy, where we look with a scope while kids are anesthetized, so they're in a sleep-like state, really is done frequently on kids with persistent sleep apnea, and sometimes it's done for kids with Down syndrome or trisomy 21 who are at risk for persistent sleep apnea to look and see if there are other sites that might be addressed in the future. And most of the studies did not split out their populations of those with Down syndrome, but in this particular one, they were able to identify a site of obstruction in all the kids with Down syndrome who were seen in that Fung study. There's a number of treatments we consider beyond adenotonsillectomy, and they include revision adenoids. If you've had a partial tonsillectomy or subcapsular tonsillectomy, sometimes they go back and take out the rest of the tonsils. And then there's things to address the palate, the nose, and the tongue base, in addition to the hypoglossal nerve stimulator. And I won't be talking about that because Dr. Nagy will, but I'll talk a little bit about the others. And this is a retrospective study, meaning done when looking back at cases that had already been completed, that was done out of the Children's Hospital of Philadelphia. And what they found is that just taking out the adenoids was pretty effective in a lot of these folks. And in fact, what's interesting is if you look at the ones who had trisomy 21, 100% of them actually had reduction of their AHI after adenoidectomy. This suggests they're really good at figuring out who to do this for. I'm not sure I can tell you I am quite as good at getting 100% response rate, but it does tell you that at the very least, using adenoidectomy alone may be useful in kids with very large adenoids and no other significant site of obstruction. And this is a meta-analysis looking at a lot of other studies that suggested that overall, when we look at kids, maybe adenoids will grow about 8% of the time. But if you look at those who have sleep apnea, the likelihood of having a revision adenoidectomy was up to 26%. So it is an area to consider looking at in those kids. There are some techniques where at the time of doing the tonsil and adenoid removal, we would actually sew the pillars or the areas around the tonsils together. And there's a couple studies, including this first one, that was done exclusively in children with Down syndrome. And what it really showed is that sewing those pillars together didn't give any added benefit. And then this is a randomized control trial of the same technique in kids without Down syndrome and really didn't show any difference either. So for those surgeons out there, this is probably not a technique that's going to add much. There's also a technique called uvulophryngal palatoplasty, and these are a lot of surgical pictures of basically different ways to try and open up the airway by the palate. The one that's probably used most commonly is something called expansion pharyngoplasty. And the goal is to really cinch open the sidewalls and pull the area forward a little bit to open up the space behind the palate. Previously, we used to take one of the muscles in the back of the tonsil, pull it forward towards the front of the mouth. And now we oftentimes will make sutures in those locations, but not separate the muscle quite as much. And if anybody has a question, I'm happy to talk about how I do it. But this is a picture of how they did it in a study in Texas. None of those kids had Down syndrome in this trial. And what they found is when they did the tonsil and adenoid removal, along with this sort of cinching up of the sidewalls, that what they really found was that those kids who had the cinching of the sidewalls did a little bit better in terms of having complete resolution of their obstructive sleep apnea. Nasal turbinate reduction is another surgery we talk about, especially in this study where they looked at kids with allergic rhinitis for at least 3 months who had nasal obstruction complaints. And they looked backwards at kids who had their tonsils and adenoids taken out by themselves, or they had this procedure done with tonsil and adenoid removal. And they found that when they were done in combination for kids with nasal obstruction and allergic rhinitis, that they had better apnea-hypopnea indices, so the sleep apnea resolved more completely. And they actually had more room in their nose. And so the assumption is they'd be able to breathe better through the nose. There's a couple of studies that were done by Dr. Schott, which included significant proportions of kids with Down syndrome. And in fact, this one exclusively included kids with Down syndrome and had a success rate of 60% when doing a removal of some of the tissue in the back of the tongue for kids whose tongue fell backwards during that drug-induced sleep endoscopy. This is a study by Dr. Probst, who hopefully isn't on because I spelled his name wrong. Sorry, it's with a P and not a B. And he looked at 13 children with Down syndrome and found a success rate of about 60% doing some of that tongue-based removal or some lingual tonsil removal. And what he found was that kids who were normal weight did better than kids who were obese, but there were very few patients in this study. So it's not definitive in terms of the effectiveness in kids with Down syndrome and obesity, but suggests that that group may not do as well. And obviously this is an area we need to learn more about. Dr. Schott also did a study where she looked at something called tongue suspension. And what you can see is a screw was inserted in the area of the jawbone, and then there's a stitch that goes around to the back of the tongue. It's a pretty minimally invasive procedure. Usually can be done fairly quickly with quick recovery. And in this particular case, she also did something called radiofrequency, which is sort of like taking a little burner and actually doing that to cause some scar tissue in the back of the tongue and make it less likely to collapse. This group was on average about 11 years of age. About a third of the kids had Down syndrome. And the success rate again was 60%, really common in most of these studies, 58% in those with Down syndrome and 66% in those without. So very effective, whether kids had Down syndrome or not. And then lingual tonsillectomy is an area that we talk about probably most with kids with Down syndrome. And that's because they're far more likely to have large lingual tonsils than kids without Down syndrome. And here's a picture of what they look like bunched up on the back of the tongue when you look with a flexible scope. If someone happens to have had an MRI, what you see is this is all tongue tissue and the arrows are kind of pointing to the edge of the tongue tissue. Here again, the arrows pointing to the edge of the tongue tissue and you see these lingual tonsils on the back, which are really filling up the airway. And when we look at studies of lingual tonsillectomy, this review showed that the effectiveness to resolve sleep apnea was 60 to about 70%. When we look at the safety of lingual tonsillectomy, this study included about a third of the kids with Down syndrome. We found that bleeding rates were really comparable to those for adenotonsillectomy, as were the complication rates. So the most common reasons came back to the ER were difficulty with swallowing because of pain and dehydration, in addition to concerns about bleeding. High-head suspension myotomy is really a technique we talk about much more in adults. There is very little pediatric data, though it is done occasionally for the kids with Down syndrome we take care of in Cincinnati. And genioglosal advancement is another technique where we actually help pull the tongue forward. Again, also done infrequently because you have to have adult teeth, all that are in order to make sure you're not risking any injury to teeth. Sleep state dependent laryngomalacia is another condition which we only really can identify using that sleep endoscopy. And what we see is when we do surgery to help fix that, and the surgery is really to clip some of the tissue on this tissue that's falling into the airway. There's a reduction in the apnea hypopnea index of almost 10 events an hour and an increase in the oxygen saturations of 2%. And it's pretty consistent across studies because this was a meta-analysis of multiple studies. Now, there are some additional procedures I'm not going to get into today, but there's often things that are bony surgeries that involve the mandible or the jaw, and then obviously tracheostomy or an airway, and the neck can be very useful for kids who have lots of comorbidities or other issues going on. And that is all I have. I'm going to turn it over to Dr. Nagy, who's going to talk about hypoglossal nerve stimulation.
Let me look and share my screen. And I think I need to put it on this. All right. Okay, my name is Sharon Nagy. Thank you so much for the introduction, having me be part of this panel. It's really an honor to be next to Dr. Ishman, who I'm basically going to be quoting her research. So I'm going to go over a new and exciting technology, which I think is hopefully the future of treatment in recalcitrant obstructive sleep apnea in the Down syndrome population. So disclosures, hypoglossal nerve stimulation is not currently FDA approved under the age of 18. So I'm going to be discussing its off-label use and some of the research that has been done to this point. So what is it? This is an implanted device originally FDA approved in 2014. That's a treatment for obstructive sleep apnea. Many children with Down syndrome will have residual obstructive sleep apnea after TNA, as you've heard, and many children are not able to tolerate CPAP. Many adults are not able to tolerate CPAP. So this is a typical treatment to offer when patients continue to have severe obstructive sleep apnea after already undergoing adenotonsillectomy. They're not able to or not willing to tolerate CPAP. No other surgical options are available or have been exhausted or are not acceptable to the parents and patient. And a drug-induced sleep endoscopy has been performed with no complete concentric collapse on endoscopy. So who is currently a candidate? Currently, patients over the age of 18. This expanded FDA approval from the age of 22 down to 18 was lowered last year, and hopefully upcoming pediatric approval will come soon. In adults, it's approved for patients with moderate to severe obstructive sleep apnea and with an AHI between 15 to 65, which is adult criteria with less than 25% being central, unable to use CPAP, no complete concentric collapse, and not obese. Under investigation currently is children and young adults with Down syndrome aged 10 to 21 with a history of prior TNA, a BMI less than the 95th percentile, severe OSA according to pediatric criteria with an AHI greater than 10 and less than 50, with less than 25% events. Again, not able to tolerate CPAP. They did identify in the study that they wanted these patients to be able to communicate discomfort, and there was no complete concentric collapse on endoscopy. Some other exclusion criteria that they put in the pediatric study were general anesthesia was contraindicated, medical instability, a medical condition requiring known future MRIs, as the Inspire device is MRI conditional, other implanted devices which could interact unintentionally, patients taking muscle relaxants or on blood thinners, and then again, the circumferential collapse scene. So step one in assessing candidacy is doing a diagnostic DICE, which you saw a lot of great videos in Dr. Ishman's talk. So a good candidate is when we see the front to back collapse at the level of the palate or anterior or posterior. Not a good candidate is whenever we see a lot of lateral wall contribution or side to side collapse, as we don't anticipate that would be overcome with the anterior projection of the tongue. Step two is implantation. So this is accomplished via 2 incisions, one in the neck and one in the chest. There's a sensing electrode that's placed in the chest between the ribs and the intercostal muscles that senses respiration. In the second incision in the neck, there's a stimulation lead that's placed around the anterior branches of the hypoglossal nerve, which stimulates the tongue to stiffen and protrude. And then the device essentially works as a breathing pacemaker and it syncs the tongue protrusion with the respiration. And typically they're providing that stimulation, 80% of inspiration and 20% of exhalation. This is just an intraoperative picture of the hypoglossal nerve. And this shows, this picture is really showing that the hypoglossal nerve innervates all of the muscles of the tongue, both the muscles that have the tongue stick out and the muscles that cause the tongue to retract. And so one very important aspect of the hypoglossal nerve implant is that we would want to only incorporate the branches of the hypoglossal nerve that are going to cause the tongue to stiffen and protrude and exclude the branches, which are more posterior that you can see coming off earlier here that cause the tongue to retract. Potential risk of surgery is bleeding, infection, extrusion of the implant, pneumothorax as we're putting that sensing lead between the ribs, pain, swelling, temporary tongue weakness, and then some may experience discomfort from stimulation, mouth dryness, or discomfort from the device. And very rarely would be tongue paresis or atrophy. These are incisions after healing is complete, both on the neck and on the chest. Typically, patients will return 1 month after surgery for activation of the device, which is accomplished with a remote control that the parents can place over the chest to activate. And then we give them a titration schedule to slowly increase the voltage of stimulation that is delivered to the tongue. And 3 months after activation, they'll return to get a titration sleep study, just like you would for CPAP, to optimize the voltage administered for the device. So this is just an example of a sleep endoscopy where there's no stimulation with the tongue base falling back and a lot of collapse at the level of the palate. And this is with some stimulation. You can see down to the area of the glottis, and there's some opening at the level of the palate there. So recently there came out with an update over the trial for patients and adolescents with Down syndrome and obstructive sleep apnea. This included 20 non-obese children and adolescents ages 10 to 21 with Down syndrome and severe obstructive sleep apnea. Their AHI was over 10 and less than 50 with a prior TNA, failed CPAP, and DICE confirming candidacy. They confirmed that the hypoglossal nerve stimulator was safe and effective. There were 2 minor surgical complications throughout the course of this study that were corrected surgically. There was a median reduction in the apnea-hypopnea index of 85%. Mean nightly usage was 9.21 hours, which is huge, as most patients won't get close to that using CPAP. And a significant improvement in quality of life questionnaires, the OSA 18. The average age was 15.5, and they had a baseline AHI of 24.2, and 70% of patients were corrected to mild OSA. In the quality of life survey, this is an 18-item questionnaire scored 1 to 7, and the mean score is determined based on that. And they showed that there was a change of 1.15 on this questionnaire, indicating a moderate change. This study, or this quality of life survey, looks at sleep disturbance, physical suffering, emotional distress, daytime problems, and caregiver concerns. And this is what I find to be the most exciting. Some prior research has demonstrated that residual obstructive sleep apnea in children with Down syndrome can affect the neurocognitive abilities, with one study demonstrating a lower verbal IQ in patients with Down syndrome with residual OSA. This is, actually, I don't think it's in print yet, but it's available online. The preliminary neurocognitive results from after hypoglossal nerve implantation in children with Down syndrome. And they looked at neurocognitive domains assessed before and after hypoglossal nerve stimulation, and it improved in all domains. Improvement in the expressive vocabulary approach significance. It's a very small number of patients. There were only 9, but I think that this is really exciting. In addition to this, the parents reported adapted and behavioral measures revealed significant improvement as well. And this is just a patient video for any parents that are on that I thought was nice.
Remember him snoring and having a hard time breathing, and as he got older, it just got worse. Even from the bedroom down the hallway, you could hear him. No one could sleep with him. We had a motorhome that we actually sold because he snored so loudly, it would keep everyone up. So for 15 years, he wore a breathing device at nighttime, a mask on his face, and still had severe sleep apnea. We had the good fortune of being referred to Valley Sleep Center a few years ago for a sleep study. And Dr. Martinez said, I think Danny would be a good candidate for Inspired. Something that everyone that's close to Danny has noticed is that he has more energy and he's more engaged during the day. He's even talking more without changing his diet whatsoever. He lost 10 pounds. If there's an opportunity to make his life better and actually increase his health and lifespan, why wouldn't you do it? Are you happy? Yeah, I'm happy too.
It just goes to show like what a significant impact and quality of life this can have for both patients and caregivers. Oh, sorry. And then thank you. I'm happy to answer any questions. I'm sure the rest of the panelists will as well. This is just an intraoperative stimulation that you can see here of the tongue while we're testing the device. Pretty cool stuff. All right, I'll stop sharing.
Thank you to the to the panel. That was a cool video. Those were great talks. I'll just go straight to some of the questions in the chat. And obviously, if you all have any questions or feel free to weigh in. But we had 2 questions. One was, do you repeat your sleep study? So you have an outside sleep study when a patient comes to see you. Do you repeat it, or do you just rely on it 100% or 80% or 90% of the time?
I don't typically repeat this sleep study. I think sometimes in this patient population, it's very difficult for them to get a sleep study and to get through that night. So unless the parent is telling me this doesn't match what my child does at home, that would be a scenario where I would consider repeating it. But otherwise, I don't typically repeat it.
Dr. Druick?
I also repeat it very infrequently. So again, like Dr. Nagy said, if the clinical history doesn't match what I'm seeing in the outside sleep study, then I'll repeat it. And then sometimes I feel that it's important to get additional parameters like carbon dioxide monitoring, which sometimes are not present in outside sleep studies. So I'll repeat it. But I think that out of all of the patients I've seen, the incidence of repeating a sleep study that has been done previously at an outside center is like 5%.
So I would say we also very infrequently do it. The one caveat I'll throw out there, which I sound similar to what you're talking about, Dr. Druick, is that if kids have a study in an adult lab that doesn't use the same scoring as pediatric labs do, we will oftentimes ask them to rescore it to see if we can kind of compare apples to apples. And if they can't do that, sometimes it'll end up getting repeated, or if there's significant changes, they lost a lot of weight, they actually had a surgery in between, because we want to make sure we're not overtreating. I will also say though, if somebody walks in and the sleep study, maybe it wasn't the best, but it shows severe sleep apnea, I don't really need to see that it was really 50 and not 20. I don't think those will make huge differences in our decision making. So I don't know a single person who's ever walked into my sleep clinic and said, I love sleep studies, I would like to go. Actually, I have one. But so I try and minimize it if I can.
And then the second question, and please, anyone in the audience, if you want to ask more questions, feel free. But the second question was about intercapsular tonsillectomies versus, I guess, the more standard tonsillectomy. Do you think it's more, do you think it's better for kids with Down syndrome? Do you worry more that there is regrowth is more frequent in children with Down syndrome? I guess that would be for the two surgeons. I guess for the sleep medicine physician as well. What has your experience been for getting outside referrals? If you know that they had an intracapsular tonsillectomy, do you see them more often come back with residual OSA versus the latter?
Does
My
anybody
personal
do
preference, yeah, go ahead.
I was just gonna say, does anybody there do it? Like the three of you are from the same institution, so.
Yeah, so as the one who probably has the largest experience of intracapsular tonsillectomies, I'll go ahead and answer in that for Down syndrome patients, because the incidence of success is so much lower than in your otherwise your child without any other issues. That is not a population that I recommend intracapsular for. Just because if there is residual sleep apnea, I don't want to even have the thought process that there is residual tonsil playing a role. So I don't recommend it.
So I would say, in general, I don't think anybody should have to get their tonsils out twice. So I'm not a huge fan of intracapsular tonsillectomy for anyone. But especially in a population that has a high risk of residual disease or recurrent disease, I don't think it's a great idea in people who have Down syndrome or obesity or some of the other conditions, achondroplasia,
Yeah,
where we
correct.
know that their likelihood is high. And I would actually love to hear Romaine's opinion too, because he does a lot of this, even though he's officially just moderating today.
We mostly do standard tonsillectomy. We have dabbled in the intracapsular tonsillectomy in what we consider to be high-risk patients for respiratory complications after surgery. There's certain patients where there's just concern, an 18-month-old who's got severe OSA and doesn't have laryngomalacia or some other finding. And, you know, the options are, okay, you're going to put a tracheostomy in, or you're going to try this. And so we've tried some intracapsular tonsillectomies in those instances, but we'll see whether or not they come back with more OSA in the future. I'm not a strong component of intracapsular tonsillectomy, but you know, I think it has a role in high risk patients if you're worried about significant respiratory events afterwards, because it does seem to be less likely. But I could be totally wrong.
I have a retort to that, but I want to make sure Sharon Nagy gets to say something if she wanted to say something in this regard.
You're on mute, Sharon.
Oh, am I still on mute?
Now you're good.
Okay, I completely agree with what Stacey said. I do the exact same thing.
The only comment I'll make is I think an 18-month-old, I'd be less likely to do a partial, only because you know they're going to go through a period of lymphoid hyperplasia. And I'd be much more worried that that kid's going to have residual or recurrent disease. The one group I absolutely have done it for repeatedly is the kids who have a lot of trismus, their mouth doesn't open very much. And I think that the risk of bleeding is lower, and the likelihood that you can get some benefit in that group. So we've even done coronoidectomies, removing some of this bone to try and get their mouth open more. And if you just can't get it open enough that they have bad sleep apnea and you're thinking about trach, like Dr. Johnson talked about, that's a group where I say, okay, it's sort of a salvage procedure. Let's see how much we can temporize and get you to a point where you can be safe.
What about Dr. Pransky says, what do you do for the child who doesn't tolerate the sleep lab study?
I'm going to add to that and just say, will you operate on a child with Down syndrome, just taking out the tonsils and adenoids if you don't have a sleep study?
Can we start by just raising our hand if we've ever done it? Have you ever gone to this? Okay,
Yes.
just checking.
Well, I think situational awareness, right? So if you have a family comes in and they say that they have their child has some significant sleep symptoms, and you do your physical exam and there's clearly tonsil hypertrophy, and the recommendation would be you should do a sleep study. Certainly that's the answer I would give if I was being held to account by certain parties. But if the family says, hey, I can't afford a sleep study, I'm paying out of pocket, or there's other situations, then yeah, I think you always situational. Remember, the guidelines are for 90% of your effort. So 90% of the time you should follow the guidelines, but there's always that 10% that requires decision-making and shared decision-making.
Dr. Zruick, what do you usually recommend?
Yeah, I mean, I agree. There's what you should do that's textbook, and then there's what's practical. And so I think that if there's clear signs of obstructive sleep apnea and the feasibility of getting the sleep study is low, then I think you just have to go with your clinical recommendation.
I would say I try pulse oximetry, absolutely, because we know a positive pulse oximetry has a lot of value. A negative one, you can kind of give or take. The positive predictive value is high, the negative predictive value is like 17%. But in those cases, I do try and do something like that. And I've even tried home studies. If you try some of the ones that are just, you know, on your hand or your finger, there's some kids who won't tolerate anything on their finger. I mean, that's a no-go too, but we've even admitted somebody before just to see if we could get overnight oximetry. If we really felt like we needed it in order for both the family and for us to feel comfortable, this is what the right next step was. So I think there are some options.
Yeah, actually, we've done that too. So we do overnight oximetry and combine that with capnography on the inpatient side once in a
Yeah.
while.
And I'm sure you're going to mention too about the whole issue with averaging. So a regular pulse oximeter on the floor averages over such a long period of time, like 20 seconds, that you need an oximeter that's going to average over 2 or 3 seconds. So you can really pick up, especially with young kids, intermittent desaturations. And so that's the other thing to keep in mind.
I think those additional studies are really important for when you're looking at the secondary procedures after adenotonsillectomy. For tonsils and adenoids, I make the families promise me that they will try to do a sleep study following surgery if they don't do one before. Again, because of the high rate of failure for just tonsils and adenoids coming out. So that's sort of the deal I make with the families, to at least try. And then if we feel like symptomatically there's more going on, that's when we'll push for the oximetry studies, the capnography, and the other things that we might need to try to get to justify that additional interventions needed.
And I think that a lot of the patients who are concerned about how the sleep study is going to go, they end up being fine. There's
Right.
very few
Agreed.
of them not able to get the information that we need.
Agreed.
Yeah, this is again the value of a pediatric sleep lab. A lot of times it's
Yeah.
really different than being in a place that's not used to taking care of kids with Down syndrome.
What are the key points that you hit with every family? You know, new visit, child have high risk for OSA, they've been referred to you. What are the key things that you think physicians should go over with the family, and what are the things you would say to families listening?
So I just do a lot of education in the first meeting, you know, what obstructive sleep apnea is, what kinds of things can be causing the sleep apnea, all the symptoms, what is entailed in the sleep study, and what it's going to look like after the sleep study, what the treatment options are, what our first line of treatment is, second line of treatment, prognostically what to expect in terms of if we're starting CPAP, how long that's going to last, which obviously is hard to predict. And then I think a lot of those kids are super sleepy. They need lifestyle modifications. And so I start the treatment, and then in the follow-up visit, kind of tweak some of those things, look at the mask fitting, and then go over lifestyle modifications if we need to do that.
What are some of the examples of lifestyle modifications you recommend, or you're looking at?
So like going over sleep hygiene, you know, what their sleep hours are, limiting naps during the day, exercising, watching what they're eating. Things that are hard to have the motivation to control if you're so tired.
I would say we also really try and make sure we include shared decision-making. If you guys don't mind my sharing my screen for one more second. Well, it was a lot more than 1 second. I was doing it before, but anyway, we have created some shared decision-making tools where we talk about, you know, our options with mild sleep apnea, our options with moderate severe sleep apnea, and talk about at least with some data behind it. And then the backside of it, honestly, is us being able to show, like, here's the site of obstruction that we're seeing, and this is the kind of surgery we're considering. Again, much more commonly, these tools are for after TNA. But I do think it's really valuable to feel like everybody's understood sort of this apples to apples conversation. And we even did some assessment to say, if you use the shared decision making or not. We did a randomized trial. Even CPAP use actually was higher in the people who made the informed decision to use CPAP. And so I do think that's an important piece too, is to try and talk through some of those things.
Dr. Nagney?
For my kiddos with Down syndrome, I plant the sleep seed early. Like when I see them as a baby for like failed hearing screen, or I'm seeing them for ear tubes or whatever, feeding difficulties, whatever it is, I talk to them about sleep every visit I see them. And I tell them from the beginning, before age 4, we're going to get a sleep study no matter what. Because sometimes I feel like families are often like, why do I need to get a sleep study? I don't see any symptoms. And so I tell them from the beginning, remember, like, this is what we're going to do, like before age 4, no matter if you see it or not, and I'm screening for it every visit, we're going to do this. So I think that that's also important, because some parents don't understand, like, why do I have to do this if there's no symptoms? And it's easy because a lot of kids maybe don't have a good correlation between like parental observation and their sleep study and the severity on their sleep study. So I think having those early conversations about sleep, like, this isn't affecting you yet, but we're going to get there, is important in the Down syndrome population.
There's another question in the Q&A that says, for hypoglossal nerve stimulator, are there any precautions you take when you take a child to the operating room? Not 100% clear. I mean, if you, Ronald, if you want to re-comment on it, like, is there anything specific you're interested in? But a general question, are there precautions that you take for this procedure?
It sounds like we're talking about things like worrying about cautery and other things. I have taken somebody to the OR for who's already had a hypoglossal nerve stimulator for something else. And
the device need to be deactivated. Okay.
So the device is not on. It's not like a pacemaker that's on all the time. It's not on unless you turn it on and push the remote and activate it. So the advantage is that it's not live unless you turn it on. So you can ask people to bring the remote. I have not had anybody who showed up with it on by mistake, because it's a little weird and uncomfortable to run during the day. Although I definitely have some people who like, it's too much of a pain. I go to the bathroom with it on and then go back to sleep. So, people have different thoughts, but if you worry about things like cautery, I do try and make sure that you're putting your ground somewhere, away from that area, in terms of the monopolar cautery. But also I usually just try and make sure I use bipolar cautery. I can't think of a situation where I couldn't just switch to it and be cautious.
So what do families want to talk about the most when you see them?
In the ENT clinic in general?
No, for Down syndrome families who have children with Down syndrome, they have OSA, they come in to see you. What are the most frequent questions that you get, frequent concerns?
Most of the people who come see me is because they really are not huge fans of their CPAP. And quite honestly, if I go through that shared decision-making tool and talk about the other options, I find many more of them understand why we think CPAP is such a great value. It's more effective than anything else I can offer you. The risk is lower. There are definitely negative consequences to everything. But I actually think that whole shared decision-making conversation is really useful in that regard. And then there's people who've tried it. They've done desensitization, they've done everything else. And they're like, I'm just done with that. What's the next? What are my other options? And so in that case, we will go through, depending on the level of sleep apnea, everything from observation, medical treatment, oxygen therapy. And there are some out-of-box solutions. Like oxygen therapy is not something you usually consider in older kids for sleep apnea, but if you don't have any other option and it actually looks like it mitigates things, then you just have conversations about what are long-term consequences of untreated or undertreated sleep apnea. So those are a lot of the conversations I have. Quite honestly, a lot of people come to me because they know that we have surgical options that might be beyond some other centers. And so we have a lot of conversations about what surgical options are, but mostly we talk about how you assess somebody. So we're looking either We tend to use something called cine MRI with drug-induced sleep endoscopy. We do it under the same anesthetic. You come in, you go to sleep with anesthesia, we do your sleep endoscopy in the induction room, you go right into the MRI scanner. And then we have both of those talked about a week later at a case conference. And we come up with options with our pulmonary and plastics and genetics. And gosh, we have an aerospace engineer in that room who's doing research with us. So it's a broad group of people. So those tend to be the conversations. But the other thing I really think is really important is no matter who you're working with, coming up with combined recommendations is really important, because nothing frustrates families more than talking to the sleep doctor and then talking to the ENT and talking to the plastic surgeon. And we gave them 3 different plans.
Yes, Dr. Druick or Dr. Gerber.
No, I was just going to say there's another question here about dental appliances. So I don't know if Dr. Druick or Dr. Nagy or Dr. Ishman want to talk about where they use that in our children with Down syndrome.
I actually have not referred any of our children with Down syndrome for dental appliance. So I think the value is, for very mild, in mild sleep apnea, I don't know what the success rate is, but I know that very few people would be eligible for it because it needs to be done once your jaw and mouth is fully formed. I don't know, Dr. Ishman, have you had success referring out for that?
I have, but it tends to be more in adolescence. I will also tell you, I usually present it as an option, and I make a joke, like, unless your mom or dad's a dentist, this is probably not a great option. And like several of them have been like, well, I'm a dentist. So I'm like, because if you want to remake them every time they get a new permanent tooth, like that's fine, but it's an expensive option if you're not somebody who makes them yourself. I had 1 or 2 people actually try it. They didn't do all that well with it, but I will tell you, kids who hate CPAP actually do much better with a dental appliance than you think they're going to do. So when they can compare it to using CPAP, and the data is the same for adults, right? When adults have tried CPAP first, they're much more likely to be comfortable with a mandibular advancement device or some kind of dental device. So if you've tried CPAP, haven't found it to be useful, have permanent teeth, I actually found, like, in that, especially in that 16 to 21-year-old range, I've had pretty good success. And many of the families didn't think they had a snowball's chance. And they did pretty well, but not little kids unless you want to remake those like all the time.
Mark, have you recommended any families to get dental?
Very rare occasion, very rare.
Yeah, we've tried some. We've actually have an orthodontist come to the sleep conference, and a few families have gone and tried it. But it's not, CPAP is the standard recommendation for most families if they have residual OSA. I'm just curious. So one of the things that I see a lot of is obesity. It's a major problem, particularly adolescents. When we look at our kids who have severe sleep apnea, they're almost all obese. And I'm sure it's a problem with you all too. So I'm curious, how do you tackle this? Because it's a major issue. It's too hard for you.
Yes, it is a major issue. And I think there's so many confounding things that can lead to this issue. It's a difficult thing to really make a dent in. So I think like thyroid issues can contribute to it, and then just that uncontrolled sleep apnea. So I also spend just a tremendous amount of time trying to figure out ways to get the CPAP to be tolerated, because I know that if the CPAP is tolerated, this child is going to have more energy, chances of increased activity or energy during the day is going to be higher, which is what's going to make the biggest difference on the weight. But the compliance rate with CPAP is just so low that children are sleepy, and then it's hard to motivate them to lose significant amount of weight. So I think just repeated conversations and engaging the family and just making small changes, go for a walk, 15 minutes, a few times a week, just a little bit of activity, and just making those small changes in every conversation.
We also have a nutritionist in our clinic. I will tell you, my colleague, Dr. Amin, felt so strongly about getting it when we were doing a budget a couple of years ago. And I was like, I don't know, it's going to make a big difference. I was 100% wrong. he was 100% right. I'm glad he was right. But just having somebody in the sleep clinic and who does telemedicine follow-ups has really been great. I also think we should consider bariatric surgery more commonly for some of these kids if they're having, especially if they're having other comorbidities, not just sleep apnea, but especially the kids who have cardiac issues and, are getting diabetic, lots of other issues. And so I actually was glad when the American Bariatric Surgery Group recognized that you don't actually have to be part of shared decision-making, meaning you can have kids with developmental delay who can make some of the lifestyle changes and include them. So I would say, yeah, I agree with all of you guys. I think it's really important. I will also say though, sometimes, you end up doing sleep surgery just to help mitigate some of the sleep apnea. They've really failed some of these other things like dental appliances or CPAP. And we know that maybe it won't be a full home run, but I think improved partial treatment of sleep apnea can even sometimes get people to the point where they are not so ungodly sleepy that they can actually participate a little bit more in some of the things that they need to do to lose weight. And the other thing that super sucks is that metabolism in kids with Down syndrome, they did some studies in genetics in our group. You just can't exercise your way out of it. Like, it's not that easy for any of us, but it looks like you can't really rev up your metabolic rate very much with Down syndrome in comparison to some typical folks. And so I think it's really unfortunate. It's all about the number of calories going in. And it's a hard conversation to have because I'll talk to families who are like, he's dancing, he's running, he's bowling, he's doing all this active stuff. But unfortunately, it's almost exclusively about calories in, and it's a hard conversation to have when you have other kids who maybe are able to rev up the metabolism a little bit more and eat the same stuff.
You're muted.
I think you're on mute, Dr. Johnson.
I'm on mute. Okay, Dr. Nagney, did you want to weigh in?
I agree. It's a huge problem and it's really difficult. And I quite honestly probably don't spend enough time and effort delving into that with patients and families. I think I say a very brief, like, lifestyle, diet, physical activity is really important, and weight loss is encouraged. And I probably don't give patients enough tools or help to accomplish that. We do have, a clinic here for patients with obesity that we can refer to that's kind of managed by endocrinology that helps with and has that nutritional aspect and things like that. So I will refer patients over there, but I probably don't do a good enough job myself, honestly.
Do you guys have a multi-D sleep conference at Phoenix Children's?
We do. It's headed by a sleep medicine physician, Dr. Drick. We have another colleague in neurology, in addition to an ENT surgeon and respiratory therapy that helps kind of with desensitization and things like that.
It sounds like we should be inviting more nutritionists to come. I know we have a nutritionist in our complex airway clinic because a lot of those kids have G tubes and are underweight. They have a different problem. I talk to families now when I see them between 1 and 4. I talk to them about obesity then, and I tell them, look, this is building good habits now. You can protect yourself in the future. And I know it's tough. And I just tell them that the kids who have severe sleep apnea as adolescents, they're almost uniformly overweight and obese. And it's become very difficult to treat. And they don't want to wear the CPAP. Sometimes we can get them to do it. Often we can. But if you can get them to not be so obese, the sleep apnea becomes much more manageable. So anyway, I hit it very early. The other thing is, so I know the guidelines say that you should get a sleep study between 1 and 4. That's a pretty long range. How do you play that out? Do you just say when they're 1 year old, you're getting a sleep study, or do you say, okay, 1, you ask them how they're sleeping, and then if they get to 4 and they're still not having any sleep problems, then you get the sleep study and you just do it as, you know, you do it if they have symptoms when they're earlier. I've always been curious about that recommendation.
My answer is 4.
My answer is what you said, Romaine. Look for symptoms. If they have symptoms earlier, do something. Otherwise, do it at 4.
Dr.
right.
Ishman and Dr. Johnson.
Very good. All right, so we still got, we could do another 5 minutes and finish up about 8:15 if that's okay. Did anybody have any questions that you would like to ask? I've been asking you all questions. Is there anything you would like to put on the table? So, you know, allopathic medicine, since I'll go ahead and ask another question. I know that, you know, we tend to practice allopathic medicine, but there's got to be homeopathic medicine and remedies. And I'm sure families have come to you with various solutions, or I'm just curious, what are some of the things that you've had families talk to you about? And has anything surprised you? Like the family has brought something to your attention and you said, and you looked into it and then you realized like, hey, maybe there's some efficacy to this therapy. No?
Not any like supplements, but I will say our sleep medicine colleague in neurology, he's a DO and he is very much an advocate of myofunctional therapy or oral myofunctional therapy for patients that can comply with that treatment. He feels like it's a good adjunct, essentially like tongue exercises. So, you know, we will, for patients that, you know, want to try to do anything and everything, that's something that I will bring up with them, trying to think of some other alternative therapies in addition to that.
Didgeridoo. There's one
No
good
one.
article on adults. You can use a didgeridoo and it'll reduce your sleep apnea because it's basically myofunctional therapy because you have to learn how to do circular breathing.
Interesting. Did you guys, so I've had several families come to me and say that in their Facebook groups that tongue-based surgery, lingual tonsillectomy increased the risk of oral aversions, and that they had children who were actually feeding pretty well, and then they went under a tongue-based procedure and now they're not eating as well and it's persisted for months after the procedure. Have you all heard of that or seen it?
Not really.
No.
Okay.
I have seen
So-
some patients initially post-operatively, maybe it's just, you know, just like after a TNA, they don't want to like eat or drink. And I've seen some patients maybe have some of that right in the early post-operative period, but not long term.
Dr. Druick, have you seen anyone come in with that?
No, I haven't.
Okay. It may, this is also hopefully this family's not listening. This is also a family that said, I need to call Dr. Ishman and ask her what to do.
But now you can tell them that we've consulted.
Yeah, that's true. I've talked to you and you told me everything that I said was correct. Quickly, I know Dr. Ishman, you mentioned using a disease-specific quality of life instrument. Do all of you use quality of life instruments? Do you use disease-specific? Do you use global? How do you measure those outcomes?
We use both a global one like the PEDS-QL and we use an OSA 18. We do include questions from the PSQ, which is sort of a balance between really being a symptom questionnaire and having some quality of life pieces in it. And then depending on the time frame, we've actually gathered some other things that looked at decisional conflict, FICT, and family impact and some other things, but we tried to do those in sort of shorter bursts because they are a lot of effort for the family, and trying to be minimal with that we think is good. But we also try and send it to them ahead of time so they can fill it out and have it completed before they come to clinic. So hopefully we're not wasting their time. They can do it while they're watching commercials on TV or playing a game on whatever system they're using.
Dr. Druick?
So we also use sleep apnea questionnaires and then a sleepiness questionnaire that they fill out.
What about Dr. Gerber, Dr. Nagme? What do you guys use?
We're all part of the same system, so the answer is yes.
What do you, for Dr. Ishman, for the PEDS-QL, which part is most impacted like family functioning, cognitive functioning? Do you see much difference? Do you compare them to in other patients in the system? Like we use it for tracheostomy patients and complex airway patients. And they're always, the biggest concerns are worry. Those scores are very low, and daily activities. Tracheostomy families, they struggle to just do things like go grocery shopping.
So I think behavior is actually what's come out for us the most. Families are most concerned about behavior. And we actually did focus groups with families. And we realized of all the things that we were measuring, like behavior is actually not very easy to measure with like a little quick survey. So it's the thing I think we're doing the worst job of assessing, and I'm sure we can do it subjective assessments, and parents are doing that all the time, but the objective assessments of behavior usually need to be administered and usually aren't short. And so if anybody out there has the short behavioral therapy assessment that you have figured out, please email me.
Okay. Well, I don't see any other questions in the Q&A or the chat. And it's 8:16. Would anybody like to we give some last words, and then I guess we'll finish up. Maybe we'll start with Dr. Nagny, then we'll go to Dr. Ishman, and then we'll go to Dr. Druick, and then we'll go to Dr. Gerbert. That's how I see you on my screen.
Thank you so much for including me. This has been fun. Please reach out with any questions. Be happy to answer them after the fact if they come in.
I would just say, tell parents not to give up on treatment. So there's lots and lots of options. Different things happen at different developmental ages too. Even if you can't do it when you're 3, you might be able to do it when you're 5. And that the impact that families see of us treating their kids for sleep apnea is gigantic. And so keep with it, or at least keep in touch with us so that as new things come down the pike, we can help you and see if they might help your kids.
I feel so privileged to have been part of this. I learned a few things, and my 2 cents is that sleep impacts your overall well-being. It's sometimes underrated, so it always needs to be on your radar.
And I could not have said it better. So just to say thank you, Romaine, to all of you for helping to put this together tonight. I hope those of you that attended learned a little something. I know each of us as the panelists probably learned a little something. And I'm very appreciative. So thank you all for taking your time. And I think for those that had signed up that didn't make it, I'm sure you'll see this but we'll get this out and published so that everyone has access. So thank you all.
All right, I will also say thank you all, and thank you to the panelists. I actually learned a lot too. It's always great talking to you all, and great seeing, Mark and Stacy, and then Sharon and Rupali. Nice to meet you. Hopefully I'll get to see you live and in person. COSM is in Dallas this year, so ABEA, our national meeting. So please come and hang out with us. Maybe we can convince Mark that we should have a panel at COSM.
There you go.
Anyway,
Perfect.
Anyway, all
That
right,
sounds
guys. Everyone in the audience, thank you so much for joining us. Be safe. Again, you can email us, look for a video of this talk to come out in the next week or 2, okay? Hope everyone's doing well. We'll see you soon.
Bye all.
Bye.